So, sorry that I'm late, but we had important business at our General Assembly. So my name is Markus Cornberg. I'm member of the Scientific Committee and the Governing Board of EASL, and would like to welcome you to this EASL press conference. And just that we keep going and do not lose further time, I would like to ask Chiara Mazzarelli to give us her presentation. Sorry.
Good afternoon, everyone. First of all, I would like to thank you, EASL, for the invitation and the great opportunity to be here today and to present this research. HCV-related liver disease has remained the most common indication for liver transplantation in a majority of the Western world for decades. But as we know, the recurrence of the infection is universal after the transplant, with roughly 30% of people becoming cirrhotic within 5 years after the transplantation. And the aggressive recurrence of HCV infection in the liver, in the transplanted liver, and the lack of effective treatment has led to a reduction in graft and patient survival among these transplant recipients. But the introduction of DAAs, direct-acting antivirals, has completely changed the scenario of our clinical practice. As we know, DAAs are effective, very well tolerated, with more than 90–95% of patients reaching and achieving the eradication of the infection. And as hepatologists, we know that the eradication of HCV infection is associated with multiple benefits. In fact, it's associated with the reduction in overall and liver-related mortality. It's associated to a decrease in the number of decompensating events, such as ascites or encephalopathy. It's associated with it's also associated with an improvement, or at least to a stabilization of liver function in around 50% of people treated with DAAs. But two questions still remain unanswered. And with our research, we won't try to give an answer to these questions. The first one is, how fast is the number of liver transplantation for patients with HCV infection declining in Europe? And the second one is, are liver transplant recipients with HCV infection surviving longer than in the past? So let's analyze our result. We have analyzed the last 10 years of liver transplant in Europe. And as you can see, we have divided this period in 3 different parts, according to the HCV treatment available at that time. So in blue, we can recognize the interferon era. In red, the PA area, the first generation of DAA's treatment. I will remember you based on interferon 2. And the green one, it's the DAA's era. It's completely interferon-free treatment. And as you can see, the number of transplants in Europe in the last decades has not changed. But if we split and divide the transplant according to the 4 main etiologies for liver disease, we can see here in blue that the need for liver transplantation for patients with HCV infection has started to decline since the introduction of DAAs. And in fact, we have found out that the number for liver transplant has decreased from 23% in the interferon area to 10% in the DAA's area. But what about the other indication for liver transplantation? We didn't notice any modification in the number of liver transplantation in patients transplanted for alcoholic related liver disease, for HBV, but we notice a slight increase in the need for liver transplantation in patients transplanted for NASH cirrhosis. And in addition, if we further divide the data according to the two principal indications for liver transplantation, end-stage liver disease and ACC, the reduction in the need for liver transplantation, you can see here that in both groups we have observed a reduction in the number of transplantation for HCV infection. The second question, so that we want to try to give an answer is, are liver transplant recipients surviving longer now than in the past? And I think this is the most remarkable and most impressive finding of our research. In fact, we have noticed that the 3-year survival of patients transplanted in the DAS area has drastically increased compared to the survival of patients transplanted in the interferon area, as you can see here. In fact, the 3-year survival of patients with end-stage liver disease improved from 65% to 76%. And a similar result, it can also be seen here in patients transplanted for ACC in HCV-related liver disease. And also in this case, we can observe an increase in the 3-year survival of patients transplanted for HCV infection. In conclusion, the message that I would like you to take away is the following, that the need for liver transplantation for patients with HCV infection has decreased since the introduction of the ACE treatment. But I think that the most impressive findings in this study, that finally this is the first study based on a large European cohort that has proved that the ACE can increase the survival of patients transplanted with HCV cirrhosis and HCC in HCV cirrhosis. And finally, I would like to thank you all the people who contributed to this research, with a special thanks to my director, department director, Dr. Luca Belli. Thank you very much indeed for listening.
Thank you very much, Dr. Mazzari, for this very important data. I mean, this really puts also all into perspective, you know, who criticize or questioned if SVR has really an important impact also on really relevant outcomes. Are there any questions from the audience? Yeah? Do we have a microphone?
Hi, this is Ed Sussman from MedPage Today in the United States. Is there any reason why you would not think that these figures would be similar in North America?
Yeah, we know from the USA study that it's already proven that there is a reduction in the need for liver transplantation for HCV. But I think that this is the first research that have proven that there is also an improvement in 3-year survival of this type of patients. And finally, we are reaching, from our point of view as hepatologists, you know, that the HCV survival after transplant is really similar to that of patients, for example, affected by HBV infection. So finally, this is, I think, something really important for us and for our clinical practice.
I may have the final question. So you showed the decline of HCV-related or HCV patients. What about the patients with hepatocellular carcinoma? Were those increased, and were those also some who have HCV-related HCC? Could you?
We noticed that there is also a reduction in the number of liver transplantation for patients with ACC in ACV cirrhosis, and the only things that we have found out that there is a slight increase in the need for liver transplantation for NASH, and I think this is quite important for the future for our clinical practice in Europe, that probably we will see more patients transplanted for NASH in the future.
Yeah. Okay, so thank you again for this important talk. So now this was hepatitis C, C like cured, and now we come to hepatitis E, like emerging, as also quoted by Heiner Wedemeyer yesterday in the postgraduate course. And Professor Lohse from Hamburg is now presenting data, very important, I think, in Hamburg. University of Clinic of Hamburg is one of the very few places in Germany where actually blood products are tested before giving to patients. Professor Lohse.
Can I have my slides? I'm stepping in for Sven Pischke, whose wife started with premature labor. Do I have to do something to...
Yeah, here.
Okay, sorry. So he had to go home. And he is sort of the enthusiastic hepatitis E researcher, together with young investigators who are also in the room and can maybe take or answer some questions, Thomas Horvatitz and Dirk Westhölter. We have on various posters our results discussing the significance of hepatitis E infection in these days in Europe and the significance of testing blood products. And EASL, always being ahead of time, already gave a recommendation that should be done, and we give the evidence why that recommendation is correct. Hepatitis E virus is an RNA virus, has different genotypes, and genotype 3 is the one that we see in Europe. It seems to mainly live in raw pork, and that is probably the source of infection in routine people. But the significance of infection via blood products is still under debate. It has been described already more than 10 years ago that there can be a chronic hepatitis E infection, while it was previously believed to just be an acute infection. And there are treatment options now, the obvious one being ribavirin and reduction of immunosuppressive therapy in those patients in whom they are receiving such therapy. The relevance of transfusion-transmitted hepatitis E is under discussion, and this is what we're addressing. These are German numbers, the number of reported cases of hepatitis E, and you can see that 10 years ago it seemed to be an obscure rare disease. We don't believe that the disease has become more common, but there has become more awareness of the disease. It's being diagnosed more commonly. It's not occurring more commonly. So clearly we have been overlooking this in the past. What is the relevance of an acute and chronic hepatitis E infection? And we've been studying this together with Hanover as in tertiary referral centers. We've looked at 150 patients who had a PCR-documented hepatitis E infection over the past 8 years, and about half of them occurred in immunocompetent people. And in these, only a few had travel-associated hepatitis E infection. Most of them were acquired in Germany, presumably by raw pork. 9 of these patients actually had underlying chronic liver disease, and in those of them, it was often a very severe disease. 4 of them had a severe hepatitis, and 2 actually had a fulminant hepatitis. 2 patients went on to acute and chronic liver failure and died from the infection. So even in an immunocompetent or reasonably immunocompetent patient, chronic liver disease, of course, is a limitation of the immune system. This can be a fatal disease. What about the immunocompromised person? All except 1 acquired the infection in Germany. The majority of them were organ transplant recipients, but there were also patients with hematological disease and rheumatological diseases. Just over half of them received ribavirin treatment, and most of those treated cleared the infection, and their ongoing trials on reserve treatment if ribavirin treatment is not sufficiently effective. So ribavirin treatment for the majority of patients actually is effective. Travel-associated hepatitis E actually primarily is a more severe disease than German-acquired autochthonous infections with hepatitis E, with higher bilirubin levels and higher transaminase levels in immunocompetent patients. And it is, at first sight, milder disease in immunocompromised patients, but milder disease also means delayed clearance of hepatitis E virus, which was significantly longer, and therefore you can have chronic disease. So about half of hepatitis E infections occur in immunosuppressed patients. Immunocompetent individuals can have a fatal course. Ribavirin treatment is successful in most of the immunosuppressed patients, and the immunocompetent patients don't require that treatment. So it is a relevant infection, both in the immunosuppressed and in the immunocompetent. And this is important information for the second question: what about blood donations? So how frequent are blood donors harboring hepatitis E infection? The previous study was already published in the Journal of Hepatology. We continue screening every blood donor, and here we are reporting our one-year experience, showing that 30 out of 29,000 blood donors actually had hepatitis E viremia, so it's a 0.1% prevalence at any time point in healthy blood donors, much higher than was expected in the past. Now, is it relevant? If this is a typical Sven Pischke slide, I should add, is it relevant to transfer hepatitis E virus? So we looked at hepatitis E infections in patients seen at our hospital, immunosuppressed patients, and 20 out of these 37 patients were organ recipients, 6 had rheumatological diseases. 12 out of these 37 hepatitis E patients had actually received a blood product within the past 4 months. So it's to be assumed that at least a third of the hepatitis E infections in the immunosuppressed patients that you see at a tertiary referral hospital actually acquire their infection not through pork, but through blood transfusions. The course of the disease was chronic in 11 out of the 37. Again, 4 out of the 11, so 1/3, had acquired the infection through blood transfusion. And they are what we would consider the high-risk group that we should have avoided by screening blood transfusion, and that we can avoid by screening blood transfusion. So this strongly supports the guideline by the recommendation by EASL, saying that not only patients with abnormal liver function tests who have received blood products should be tested for hepatitis E, but that blood donor service should screen hepatitis E by PCR in order to avoid passive transfer of hepatitis E. So in conclusion, a third of the immunosuppressed patients with chronic hepatitis E infection were receiving that infection via blood transfusion, or at least had a transfusion history, making it highly suggestive that they received it that way. Prevalence of hepatitis E viremia among blood donors in at least northern Germany is high, with 0.1%. And I have not gone into the details. One of the most risky procedures we have identified, which we have stopped doing, is, unless we have checked blood products, is plasmapheresis in transplant rejection episodes in heart transplantation. We identified that as a particularly important risk factor. So we strongly suggest to test blood products for hepatitis E, especially if blood products are given to immunosuppressed individuals. And there were many people who worked on that project to whom we would like to express our gratitude today. Thank you very much.
Thank you very much. I think very important and interesting data. And my first question would be, how did you convince a university hospital to pay for screening? Because it is costly. And so far we had not this big evidence. And, you know, University Hospital of Hamburg is 1 out of 2, I think, but Önhausen also screens. places where HEV is screened. And do you screen only the blood products for immunosuppressed patients, given to immunosuppressed patients?
No, we screen all blood products, and I can give various answers to your question. I can give a political one saying we want to be the best hospital, providing the best care. That's why we test our blood products. We, of course, initially had the opportunity that we got the assay for free for the first samples, and by the pilot trial, which we have now published, it was clear to us that we should continue doing it. And this is what we're presenting now as a quality control measure. Is it appropriate to continue screening? And clearly, yes, it is.
Yeah. I think so. There's a big debate also in several communities that, okay, even if you screen the blood products, the patients can still get it by this food, by raw pork and so on. I mean, there is a discussion, but I completely agree this is the way we should go, because we should not intentionally infect our patients with HEV.
And I think that argument that you're just bringing up is just an additional one. Should we advise highly immunosuppressed patients to avoid raw pork? Yes, we should.
Questions here? If you have a microphone in the front.
It's coming.
Hi, Neil Osterweil with Medscape Medical News. What's known about the worldwide prevalence of hepatitis E?
Hepatitis E prevalence, maybe Dr. Hoffman wants to ask us. We have looked at the published studies. There is a worldwide prevalence. Also in the Americas, at least we know. There seems to be an association with pork, so it is related to pork consumption worldwide. So certainly North America is a risk region, and it's probably more related to pork than it is to poor hygiene.
I may comment also on this. Of course, there may be regional differences, and of course we have different genotypes, and in the tropics like India and so, genotype 1 is the most prevalent, and it's not related to this kind of transmission. But I think in Europe it also depends. In southern France, there were the first reports. I think the prevalence is much higher there because of this food they have there in southern France. There may be other regions where we have lower prevalence, but it's neglected. Yeah, it's not. You see the graph also in Germany, how it went up when we have this awareness. If more and more patients will be screened, and even there is a suggestion and model from their RKI, where we have the reports for the hepatitis E virus infection, that annually we predict an acute HEV infection in Germany from about 300,000 patients that get infected. But most of them are asymptomatic. And therefore, in the past, it was not a major issue. Yeah, but there's another question.
Yeah, Rapakowski from Germany. Can you just explain the difference of the treatment of immunosuppressed and immunocompetent? I didn't understand it with Rava.
The immunocompetent patient usually does not require treatment. They will overcome the infection spontaneously.
But I may add to this still, it's important even for competent people, because there is emerging data that HEV infection is also associated with extrahepatic manifestation. Also very important data from Hamburg, from Sven Pischke, and also from Harry Dalton from England, that there are cases, for example, of Guillain-Barré syndrome or other neurological, other autoimmune phenomena associated with HEV infection.
But there may be a reporting bias, so even though we are claiming this, we should be careful in the public communication.
It's another reason also to think about this in the future more. Yeah.
There's a microphone in the back. I think we should.
Yeah. First in the back, then in the front. Herr von Thiel.
I have two questions. The first question is: when ribavirin does not work, do we have any other options? Has sofosbuvir already failed in trials? Or
it's being tested.
It's still being investigated.
Yes.
Okay, because I saw one.
That's what I refer to. That's what I refer to when I said there are ongoing trials.
Okay, so we can still hope that there are maybe possible, potentially good results.
But we should wait for the results.
Yes, we should. I saw one where the viral load went up and down. Second question: when you screen for hepatitis E, would you only recommend a PCR test?
Yes.
Because the antibodies are so unreliable?
The PCR test is very reliable, so we would recommend the PCR testing.
And only that, because I think
Well,
antibodies
there's
might cause confusion only, right? If you have someone with positive antibodies.
Mark Lütke Hittmann may comment on this. Antibodies have a problem.
That's why I'm asking.
Mark Lütke-Hittmann is the virologist on our study.
Yes.
So final question.
Infectious ones.
We are already very late, but very interesting stuff, of course, here in the front.
Yeah, Molly Walker, page today. EASL's given recommendations about screening blood products. Do you know of any of American medical organizations that have done so, or do they follow EASL guidelines?
Still neglected. EASL is ahead of everything.
Just a quick one, if I could. Is there any effort to screen the pork?
Is there any effort to screen the pork? I think that's beyond my competence.
But there's another problem, of course, because there's also in wild animals. And if you, for example, pick strawberries from the field, they can contain hepatitis E virus.
So wild boar is even more dangerous than domestic pigs.
Wild boar problem, yeah.
And it's not that easy to screen them.
And a very provocative...
Too few volunteers.
I mean, we have to go on, but I think it's also one of my favorite topics. But, you know, you can also argue in this way, if you are young and eat raw in this meat, you are kind of vaccinated. This is also a provocative statement. But in the end, for immunocompromised, we should avoid this, yeah? So, coming to the next topic, which is PBC. And we have a new drug approved since some time, obeticholic acid. And now we wait, of course, for long-term data. And therefore, here, Dr. Christopher Paulus from California will tell us more about this.
Great. Thank you. And thank you to EASL for giving us the opportunity to present our results here on the study of the long-term effects of obeticholic acid on liver histology or liver fibrosis in patients with PBC who have an incomplete response to obeticholic acid. So PBC, of course, is an autoimmune liver disease in which the small bile ducts are targeted, leading to biliary fibrosis, cirrhosis, and eventually liver-related death. In our current clinical practice, liver biopsy is not used very frequently, either for diagnosis or treatment guidance. The availability of antimitochondrial antibodies and other PBC-specific antibodies make the utility of liver biopsy for diagnosis fairly infrequent. And the overwhelming evidence supporting alkaline phosphatase and bilirubin as accurate surrogate markers for clinical outcomes in patients treated with ursodeoxycholic acid have also made liver biopsy less important in terms of identifying disease progression and guiding treatment. Nevertheless, liver fibrosis is an important outcome of disease, and there are some longitudinal studies that allow us to have some insights into the natural progression of liver fibrosis and PBC with treatment or those having an incomplete treatment. I showed these two previous studies here. So the study by Angulo looked at a small group of patients treated with URSO for a long period of time, 5 to 9 years, and compared them to a group of patients who had been untreated and identified that fewer patients treated with URSO developed cirrhosis, and though not statistically significant, there was a numerical reduction in the percentage of patients that had progression of their fibrosis on liver biopsy. Perhaps more relevant to our current practice is the study by Kumagai and others showing that patients that did not have a complete response to ursodeoxycholic acid continued to progress over a 10-year period. In fact, the majority, nearly 80%, had progression of at least one stage on their liver biopsy. And so in the context of obeticholic acid, the obvious question is, are these changes we've seen in liver biochemistries translating into histologic improvements as well? So obeticholic acid, of course, is a potent selective farnesoid X receptor agonist. Preclinical models have suggested that obeticholic acid, in addition to have anti-cholestatic effects, also has antifibrotic and perhaps anti-inflammatory effects. And in a double-blind placebo-controlled Flint trial was shown to have demonstrate improvement in liver fibrosis in NASH patients. And so with that background, within the POISE trial, we were interested in looking to see if this would be translated into similar effects in terms of liver fibrosis. So just as a reminder, the POISE study was a 12-month double-blind placebo-controlled study comparing placebo to 2 different dose regimens of obeticholic acid, followed by an open-label extension study. And patients that received obeticholic acid met the primary endpoint and did have significant improvements in their alkaline phosphatase and bilirubin at 1 year, suggesting that they would have better clinical outcomes. As part of the POISE study, there was a fibrosis progression sub-study in which patients were given the option to participate with a biopsy at baseline, that is within 1 year of day 0 of the study, and then they had a follow-up biopsy 3 years after treatment with obeticholic acid. And so patients that were receiving obeticholic acid in the double-blind phase then had their liver biopsy 2 years after receiving obeticholic acid in the open-label extension, whereas those patients that were randomized to placebo in the double-blind phase had their liver biopsy after 3 years of open-label extension treatment. The biopsies were staged by a single pathologist using the following staging system, essentially 6 stages, and just point out that stage 4 and 5 are incomplete and complete cirrhosis, respectively. The primary assessment here was fibrosis progression or cirrhosis, and the reason we chose this was because this is the only histologic measure that's been consistently shown to be associated with clinical outcomes. Other features that were assessed included ductular reaction, portal inflammation, lymphocytic cholangitis, and granulomatous cholangitis. 27 patients out of the 216 that were enrolled in the study agreed to participate in this sub-study. 12 of these patients had baseline biopsies only. 4 continued in the POISE trial but declined the second biopsy. Others discontinued or withdrew consent during the trial. This left 15 patients with paired biopsies. 2 of them had a single biopsy that was not sufficient for analysis, so we had 13 paired biopsies at the end of for analysis. If we look at the demographics and other features, clinical features of the cohort, they look very similar to the overall POISE cohort patients. I'll point out that all patients were treated with URSA with a median dose of 13.5 milligrams per kilogram, median alkaline phosphatase of 322. And I think very importantly here is if we look at the fibrosis stages, we see that 9 of the 13 had advanced fibrosis, that is bridging fibrosis, incomplete cirrhosis, or frank cirrhosis on their biopsy. The main result here is that the majority of patients had either improvement in their fibrosis score or no worsening after 3 years of the treatment. And so we see that 6 patients actually had improvement in fibrosis, 4 by 1 stage and 2 by 2 stages. We had 5 patients that had no change in fibrosis and 2 patients that had increase in fibrosis by 1 stage. And we also noticed that these 4 patients with cirrhosis all had improvement in their fibrosis stage. When we looked to see if there were any other histologic features that might correlate with these improvements in fibrosis, we really didn't see a whole lot, and granted the numbers are small. Over here on the left, I think it shows up as light green, yeah, on my screen it's blue. But anyway, the top patients here are those that had improvements in their fibrosis stage. Those in white had no change, and those in the peach color had worsening of their fibrosis stage. And there may perhaps be some improvement in ductular reaction among those that had improvement in their fibrosis stage, but overall there were no other significant changes really in these other histologic markers. In terms of biochemical changes that we saw in this cohort, again, very similar to the overall POISE study cohort, median decrease in alkaline phosphatase of 99 points and other changes within liver biochemistries. In terms of adverse events within this cohort, again, similar to the overall POISE study, with the most frequent adverse event being pruritus. In terms of serious adverse events among this cohort, 5 were observed in 5 patients, 1 of which was related to a liver biopsy, unfortunately, but none of them were associated or felt to be related to obeticholic acid. So in conclusion, from prior longitudinal studies, we know that patients that are either untreated or have an inadequate response to ursodeoxycholic acid are at high risk of fibrosis progression. And this study suggests that treatment for 3 years stabilizes or even leads to improvement in fibrosis with obeticholic acid treatment in this patient population. And these results are the first to provide some histologic evidence in addition to the biochemical evidence that obeticholic acid may lead to improved clinical outcomes in patients with PBC who have an inadequate response to URSO. And these are consistent with prior studies in terms of the effects of obeticholic acid on fibrosis and NASH. And finally, what we look forward to are demonstrating actual clinical outcomes benefit with obeticholic acid in PBC patients with the ongoing phase 4 COBOT trial. Thank you very much.
Yeah, thank you very much. Questions? Yeah, there's a question in the middle, microphone.
Hi, Ed Sussman with MedPage today. Dr. Cornberg, do you find these results of the study compelling enough to, would you be putting your patients with this?
So you're asking me and not him? Actually, maybe I asked him before I answer the question. So these are not so many patients in the end. Do you have any correlations of the alkalic phosphate acid response to the histological improvement? Because we saw today a very important talk also by Gideon Hirschfeld, who will later on presenting, that we saw a response of alkalic phosphate acid, but not so much on the fibrosis. So this is, I think, an important also issue.
I'm not sure that's quite right, and Gideon, maybe you can address this, but you were looking at histologic activity and not necessarily fibrosis as an endpoint.
Both.
Yeah. So I think I agree this is a small number. If you even look back though at the URSO trial that, from Angulo, they only had 16 patients on long-term URSO therapy. So these are very difficult to look at. We're unable to really find any association with fibrosis change in the alkaline phosphatase.
Not enough patients.
It's not enough patients, yeah.
And sampling bias in PBC, what could you comment on this? Maybe, there are some diseases like maybe chronic HCV where you may have not this sampling bias. In NASH, you may have a higher PSC. It's completely, biopsies are not reliable for
I think
PBC.
There's no question that histologic assessment of fibrosis has issues in terms of sampling error. I would say that it is a small number, but we did not see those at the lower stage going up, suggesting that there's a real effect there and not simply some random event.
Okay. Good. Now I try. It's very hard to answer this question in general. And you have to see your individual patient. And if a patient is on ursodeoxycholic acid and he's not responding, and he has no issues with itching maybe, because this could also be a concern, this is an option, and we are happy that we have an option. But I think it's not for a general view that you have all these patients and you put them all on obeticholic acid. We have also some patients we consider fibrates. Yeah, this is also presented last year, EASL, very important study. So this is very difficult. I think it's not for every patient with non-response to urso. In my view, I'm not sure what you think about this, but it is important that we have this drug, and it is important to have these studies, even though there are few patients. It gives us further evidence, and we need to go on this, and we have not so many patients for these huge studies. Yeah, it's sometimes a very dramatic progress in some patients, therefore we need this kind of drugs.
If I could comment on the fibrates issue, because I think that's an important one, is that I think there's increasing evidence that fibrates might be effective in PBC, but I think it's very important to recognize the difference between one study of 100 patients over 2 years and some of the longer-term data that we're starting to generate from some of these, other larger studies. So I think it's very important that when we're maybe trying to decide on which second-line therapy we're going to use, that we understand what data is behind those recommendations we're making, both the good and the bad, the risk, the benefits.
How many patients are you recruiting for the phase 4 study?
It's a event-driven study, and I can't tell you offhand exactly how many are being recruited for that study.
Okay, we need to go on. Thank you again. So now we come to another emerging topic, already suggested by some of the talks. Yeah, by the first also, increasing number of patients transplanted because of NASH. Professor Ali Chanbai is from Magdeburg, will give us some data on this emerging topic of fatty liver disease.
Yeah, thank you, Markus. Thank you, EASL, giving me opportunity to present our data on non-alcoholic fatty liver disease. So this is, everybody knows that non-alcoholic fatty liver disease is a common cause of compensated cirrhosis in Western countries. We have almost 25% of the worldwide population is affected by non-alcoholic fatty liver disease. And everybody knows also that this patient develop liver-related complications and progress to end-stage liver disease, which include decompensated cirrhosis with hepatocellular carcinoma and liver transplantation, and which may lead also, of course, to high mortality. We have limited real-world data exists on healthcare costs, healthcare resource utilization, and other health outcomes specific to the German population, and therefore our aim was to examine the comorbidities, disease progression, mortality, healthcare costs, and resource utilization among the NAFLD NASH patients. In Germany, this was a study design. It was a retrospective study design, was conducted using anonymous claims from Institute für Gesundheitsforschung from Berlin between 2011 to 2016. The time period covered by this database is limited to a period of 6 years. Inclusion criteria: patients were aged 18 years and older with non-alcoholic fatty liver disease. At NASH, this was related to the ICD code, and then followed from the first NAFLD NASH diagnosis flagged with the compensated cirrhosis patient. It's the first occurrence of a compensated cirrhosis diagnosis, and then the patient progressed to end-stage liver disease with 1 year after the compensated cirrhosis diagnosis were the progressors, and those who did not progress to end-stage liver disease within 1 year after the compensated cirrhosis diagnosis were non-progressors. The exclusion criteria, of course, viral hepatitis, Wilson's disease, Gaucher, LD, and alcohol and other diseases. So this is our study scheme. You see it between 2011 and 2016. What is important is that we have the pre-compensated cirrhosis index period 1 year, and then post-compensated index period between 1 and 5 years. And then we collected this patient and with compensated cirrhosis as non-progressors and CC progressors. Outcomes. Comorbidities were analyzed during 1 year period of 1 year pre-compensated cirrhosis index, and all-cause health resource utilization were analyzed during 1 year pre-compensated cirrhosis index and 1 year post-CC index period. And all-cause healthcare costs were analyzed during 1 year pre-compensated cirrhosis index and 1 year post-CC index period. And cumulative annual costs were examined for patient subset with 1 to a maximum of 5 years for control enrolled pre-CC index and post-CC index periods. All-cause mortality was investigated during 1 year post-CC index period, and these are the statistical analyses. So we actually have more than 4,500,000 patients analyzed. As you can see, we also exclude patients with decompensated cirrhosis, with HCC, liver transplantation, this period before, and then this patient included in our study all patients with and without evidence of decompensated ACC liver transplantation, time frame starting from the CC index quarter and the subsequent quarter. So these are our patients with this non-progressors, 455 patients, and then we have progressors, 245. So these are the demographic results for these patients, compensated for the 800 patients, and you see the total patient was 800. The mean age was 67 and 68 years, mainly males. And if you compare the non-progressors and progressors, total progressors were older than non-progressors, as you saw, there was a difference between in the age in this case. What was the importance of the study? Actually, the comorbidity profile for NAFLD NASH patient. As you can see, cardiovascular disease was almost 50% were related to NAFLD, and then we have 32% renal impairment, and then diabetes, 42%, and obesity. I think 36% is lower. I think it's much higher, but this is maybe in bias. And we have almost 80% has hypertension, and 47% were associated with hyperlipidemia. So these are the results. The annual all-cause healthcare resource utilization for NAFLD NASH in compensated patient. As you can see, number of hospitalization per patient, it was pre-compensated cirrhosis area. You see 0.78, and then after compensated, the post-compensated cirrhosis, you see that was an increase of 91%. And if you look for the patient with emergency room visit patient, it was rise from 3.54 to 7.32. It was an increase for more than 106.8%. So the mean annual all-cause health course for NAFLD NASH in our patients group, as you can see, this are the blue is the total, and then this are the red was inpatient patients and outpatients, green, and then you see here this a patient post-CC diagnosis, mean annual cause health score increased by 93%, inpatient cause being the primary driver. As you can see, that was really elevated. That was more than 214%. So mean annual all-cause health score patients for NAFLD and in our patient cohort between the progressors and non-progressors, as you can see here in the non-progressors, post-CC diagnosis, mean annual all-cause total health care cost increased by 47%, in inpatient costs being the major driver, more than 103%. To look for the progressors, and you see post-CC diagnosis, mean annual all-cause total health score increased by 180%, and in inpatient costs being the major driver of more than 411%. So therefore, you can see that the progressors have much more annual cost. The mean cumulative all-cause total healthcare cost for NAFLD NASH in compensated cirrhosis patient, as you can here see, in 5-year periods post-CC diagnosis, mean cumulative all-cause total healthcare costs increased significantly by more than 143%, and 169 for CC progressors and 132 for CC non-progressors, as shown here in the long term. There was a dramatic increase. So how was the all-cause mortality in 1 year follow-up for our patients? As you see, the total patient, almost 20% was high mortality. And if you compare the non-progressors and progressors, you see that the progressors was associated with high mortality, more than 46%. So in conclusion, German NAFLD NASH patients with compensated cirrhosis have a high comorbidity burden. Post-CC diagnosis, mean annual number of all-cause hospitalization and ER visits significantly increased by 91% and 106% respectively. Post-CC diagnosis, annual all-cause total healthcare costs increased by 93%, with inpatient costs being the primary driver of a more than 214% increase. Pre-CC index and post-CC index costs are significantly higher amongst, of course, CC progressors than compared to the non-progressors. The cumulative all-cause total healthcare costs for CC patients increased more than 143% over the 5-year period. And I think this data implicates that we need new therapeutic options for the disease. Otherwise, we will get a lot of patients with a lot of possibility, with high mortality, HCC, and liver transplantation. Thank you very much.
Thank you, Ali. Any questions? I may start. Yeah, there's a question here.
What about lifestyle changes? I saw a poster, I think, today that it works.
Of course it works. There are a lot of studies that life changes works, but these are just data from the institute. We will check, but we have to talk to our politics, of course. We have to do something, otherwise we will get a lot of patients with NASH-related transplantation.
If a doctor tells someone to lose weight, it works for maybe 4 weeks or 3 months. I see this by myself, and then it's like Pokemon Go gaming. Yeah, it works for some months, and actually there's a study, I think in the British Medical Journal, Pokemon Go players, they lose weight and so on, but it lasts for 3 months and then everything is not. So I think we need prevention measures, yeah? And this data is very important for policymakers, that we need educational programs in school and young children already, that this is a major issue.
I think so.
Yeah, there's a final question. We need to go on. Yeah, late. My fault.
You mentioned earlier, Dr. Cornberg, that you think the obesity prevalence is much higher, but there's bias. Can you explain that?
You mean obesity?
Yeah.
I think some data are not, we're putting from the doctors in their schedule, actually. I think they didn't check that. But I'm quite sure that this is just a top of the iceberg for non-alcoholic fatty liver disease. I expect that we have much more patients with NASH. Thank you very much.
Okay, thank you, Ali. And again, yeah, why not? So now we're coming, as Michael Manns always said, to the black box of hepatology, which is primary sclerosing cholangitis, PSC. And we have data now, maybe with new drugs coming up for this important disease for our patients, where we have really nothing so far. Gideon Hirschfeld.
Well, thank you very much. As you know, this will be a late breaker presentation that I'll be giving tomorrow on behalf of the sponsor and the study investigators of NGM282 and its ability to improve markers of bile acid synthesis, injury, and fibrosis in patients with PSC. And it's the results of a significant effort of a phase 2 study. And my disclosures. So I think, for this audience, it is worth reiterating the importance of finding some medical therapies for patients with primary sclerosing cholangitis. And it's been an academic venture that's been going on for many decades with little progress. It's rare, it's serious. Essentially, more than half of our patients with a diagnosis of PSC will end up needing a liver transplant. 10 to 15% of them will die of bile duct cancer. The disease is unusual as a liver disease because, of course, it's a biliary disease with biliary strictures. Patients have recurrent cholangitis, but in addition, they get parenchymal disease and cirrhosis, and the majority of patients, of course, are transplanted for end-stage liver disease. The cancer risk is unusual. It's relevant. It's not just the biliary tree, but it's the bowel as well. And within our understandings of this disease, we can see that there's clearly a very important component of cholestasis, of biliary injury. And the FXR-FGF19 pathway will not have passed you by as being a very hot topic in non-viral liver disease. Indeed, I've seen in viral liver disease. And in PSC, FGF19, this enterokine from the bowel, levels are increased. However, there's impaired suppression of CYP7A1, the key gene that FGF19 is working through. despite increased endogenous FGF19, and there's a different response to FXR agonists in terms of FGF19. So there's some interesting features around PSC and FGF19. NGM282 is a very interesting molecule. It's a non-tumorigenic, engineered analog of FGF19. It's got 95% homology to human FGF19, and it's a drug that is in development by NGM Bio, and to date over 400 patients have been treated in PBC and in NASH. And many preclinical models demonstrate that this drug potently inhibits CYP7A1 and reverses hepatic injury. And this is associated with reductions in C4 and ALK-Phos and liver transaminases, for example, in a study in PBC soon to be published. And it works through the FGFR4 receptor, that decreases CYP7A1, and the reduction in bile acid-driven injury leads to less toxic bile acids, reversal of injury, and fibrosis. And one of our surrogates for the effect of NGM282 is to demonstrate a reduction in C4. So the back data to why this went into a human trial is that in a very solid model of biliary disease that has some features of PSC, although it is not PSC, NGM282 clearly had quite striking effects on liver biochemistry, alkaline phosphatase, ALT, AST. It had significant impact on fibrosis, and of note, it had a significant impact in collagen synthesis, and I'll just point a little bit just to highlight collagen 3 in particular, because collagen 3 is something which is something that's measured in essence in a number of human studies now, and in our studies, as I'll show you in a few minutes. So the study design here and key enrollment criteria are: this is placebo-controlled, 2 doses of NGM282, a 12-week study with 1:1:1 randomization, 62 subjects, 27 sites, primary sclerosing cholangitis diagnosed in accordance with guidelines. In this study, patients who had prior features of autoimmune hepatitis or who had a small variant were included. Clinically stable so-called dominant strictures and compensated cirrhotics were also included. But patients had to have evidence that they were at greater risk of events based on biochemical surrogate, alkaline phosphatase, and UDCA use, which is still prevalent, was a stratifier. And the primary endpoint was the mean change in alkaline phosphatase from baseline to week 12. The baseline characteristics, I think, are reasonably what you would expect for this population at high unmet need. These are young patients. They're predominantly male. These patients have had PSC for around 8 years. You can see that UDCA use is still quite prevalent, despite there being no evidence of efficacy. And in this cohort, there was a mix. There were some patients who had so-called small duct disease, and around nearly 2/3 of patients had associated colitis, which is what you'd sort of expect from a broad population of PSC IBD patients. At baseline, you can see that these patients have significant active biochemical markers of disease. These are markers that predict they are at risk of future events. Although ALK-Phos has challenges as a surrogate, as you'll see, it is still a good marker of risk. And you can see that these patients had elevated ELF scores, and at baseline, they have evidence of ongoing fibrosis turnover. This is unusually really for some diseases. This is an ongoing pro-fibrotic disease where fibrosis is a major component of determining outcome. Now, if we look at the primary endpoint, we look at biochemistry, although there were some transient changes in alkaline phosphatase during the 12 weeks, at the evaluation between baseline and week 12, there was no statistical significant difference in alkaline phosphatase at comparing placebo or either of the doses, and this was the same for gamma-GT and bilirubin, and the use of UDCA was not relevant to this finding, which is in contrast to some other trials of other similar agents. However, it is of note that there is evidence of target engagement. There is significant suppression of C4. You can see that on the left in a dose-dependent manner. And on the right, you can see a significant reduction in bile acids, again in a dose-dependent manner, compared to the placebo-control group over the 12-week study period. Additionally, we then went to look on at other serum liver tests, And when we think about our patients with cholestatic liver disease, they've got cholestasis, inflammation, and fibrosis. And NGM282 did decrease significant liver transaminases, supporting that the reduction in bile acids was associated with reduction in hepatic inflammation. And you can see a significant difference for ALT and for AST at the 12-week time point, which is encouraging. Now, we already know from prior studies, both retrospective and prospective, and some of which include clinical trial data, that the composite enhanced liver fibrosis test can predict clinical outcomes and transplant-free survival in PSC. And we know that severe disease has been arbitrarily, a cutoff of 9.7 has been used to stratify, and in the context of clinical trials, changes in ELF at 12 weeks of a delta of 0.19 can then predict outcomes over a 2-year period. And that comes from the simtuzumab study from Professor Bolus. So we were very interested to see what NGM282 did to ELF in this setting. And you can see, very much in keeping with my colleague Professor Harrison, who's presenting on NGM282 in NASH, that there were significant mean changes in the ELF score at 1 milligram and 3 milligrams as compared to placebo. And that if we looked at risk stratification by looking at the patients at greatest risk who've got the higher ELF score, indeed the mean change in ELF score was greater. Now, we know that ELF is not a perfect test and it is composite, and we are all working towards better biomarkers of the fibroelastic response and matrix formation. And one such measure is ProC3, and this is measuring a part of, relation to type 3 collagen. It's a propeptide fragment derived from cleavage during deposition. And there is observational data and from trial data around serum levels correlating with fibrosis progression, identification of patients responsive to antifibrotic therapy in Hep C, and it can distinguish between patients with UC alone and those with PSC. And there is evidence emerging that it is prognostic of death or transplant in patients with PSC. So this data was therefore very exciting for all of us when we looked at the evaluation of NGM282, because there is a rapid decrease in ProC3, which supports suppression of fibrogenesis, which was not seen in the placebo group. And although not shown on the slide, when treatment ceased, the treatment group's ProC3 levels returned to the same as the placebo. So this is appealing data that this drug is having an effect on a component of the disease of relevance to patients, which is ongoing fibrogenesis. The greatest decrease in ProC3 was observed in those with the highest risk for disease progression. Again, stratifying the upper limit of normal really for ProC3 is around 10, and if we just stratify around the mean baseline for ProC3 using a cutoff of 20, much like the ELF data, we see that the greatest impact appears to be in the people with the greatest evidence of ongoing fibrosis. This drug has, as I said, been given to 400 patients. The safety and tolerability profile from this study was really no different. There were some injection site reactions which were mild and resolved. There was no difference between patients who had a history of autoimmune hepatitis or cirrhosis. There were no events during the 12-week treatment period, as you'd expect. There was no evidence of itch, and there was no evidence of neutralizing anti-drug antibodies. 2 patients discontinued due to adverse events. 1 was progression, unrelated, and at 3 milligrams, 1 patient had diarrhea, which we believe is a prokinetic side effect of NGM282. There were 3 serious adverse events, 1 of which possibly was related, although bowel obstruction is not clear how that was the case. So in summary, whilst treatment with NGM282 did not result in any sustained changes in alkaline phosphatase, it did, however, in a randomized placebo-controlled study over 12 weeks, produce favorable changes indicative of antifibrotic and anti-inflammatory activity. There were significant reductions in C4 and bile acids. There was a sustained reduction in ALT and AST, and there were highly significant reductions in ProC3, consistent with decreased collagen synthesis and fibrogenesis, and reductions in ELF score. And these findings are consistent with the similar data that's emerging for this drug in non-alcoholic steatohepatitis. The drug was well tolerated, and therefore there is optimism that we should be thinking about how to conduct future trials in PSC which use fibrosis-related endpoints in our pursuit for new patients for our treatments. And obviously we'd like to thank all of the investigators both in Europe and North America. Thank you.
Thank you. One question. Here in the front, can we have the microphone? Or you speak loud? Yeah.
Neil Osterweil with Medscape. So I didn't see it, but did you have any biopsy data?
No. So, I mean, you know, the issue about biopsy in liver disease is vexed. The issue of biopsy in cholestatic liver disease is complex. There is a role for liver biopsy in clinical trials in primary sclerosing cholangitis. I don't believe that role is in the early phase 2 studies. I do believe that if one is contemplating a registration study, then liver histology in an adequately powered study would become very important and could be very meaningful for patients.
So, and also you didn't meet your primary endpoint, wrong endpoint?
That's exactly the conclusion, as you saw on the last slide, is that this is a complex disease, and the alkaline phosphatase is an easy endpoint to think about and is definitely important around biliary injury. But we know, you know, from everything that we do and everything that we see histologically that this is a fibrosing disease. And in the pursuit of what is likely to be combination therapies for PSC, you know, therefore we do need to have endpoints which pick up fibrosis. And for the majority of the world, the reason that most patients have a liver transplant for PSC is actually end-stage liver disease from fibrosis.
Final question.
For you, Dr. Cornberg, could you sort of give us a perspective on how we should view the results, considering that we did not get the positive primary endpoint?
Yeah, I mean, for the discussion of primary endpoint, maybe a bit too early even, yeah, but I think it's groundbreaking because we had no really studies in this disease, and it's a disease where we have really nothing, and even UDC, we don't know if it's really effective. Yeah. And therefore, this is so important, and that we have now these kind of studies, and I think congratulations on this, even though we don't really know in the end what is the outcome of the patient in the end. But we need biomarkers, we need to look at biomarkers that are associated with outcomes. If this is ALP, we don't know, for PSC. So there is not much done, and I think this is also gives more food for research, for more data. I think, therefore, this is so important. Okay. Thank you very much again.
So, wait.
Okay.
Please?
Oh, we have 50 minutes left. Maybe you can ask him afterwards.
I just want to clarify what you were saying. So you're really glad that they did this trial, but you wouldn't give this drug for this?
This is maybe too early to state that we give this drug. Yeah, I mean, this is preliminary data, and this is the first data. And I think we need more discussion after you presented after Gideon Hirschfeld will present this as a late breaker, and we need scientific. I saw this for the first time. This is late breaking and really very important, but so far too early to state this. Now, WHO, give an update on global access to hepatitis C treatment, upcoming guidelines. Thank you very much, Dr. Gottfried Hirnschall from the WHO.
And it's a pure coincidence that there's another person with a German accent, right, in this session. I'm actually Austrian, I have to say. Just want to start out by thanking EASL for including us here. And in a way, I'm the odd outlier here, because I'm obviously not presenting any research finding. But the idea really is also to say, how does all this fantastic work, this research, this drug development that's been presented, how does it ultimately come together and translate into access to people on the ground? And when we say access, it's obviously to people that will live in different parts of the world, in rich countries, in poor countries, poor people in rich countries, people who have other characteristics. There may be persons who inject drugs, so there may be migrants, etc., etc. So really, the focus of our work is very much on a public health approach that actually triggers access to everybody who needs it. And these are still large numbers that need to be reached. We have just a month ago, so we're not launching it here, it's already on our website. We've just a month ago launched an access report, and I'm just highlighting a few summary findings of that, and I'm going to give you a short update also on where we are with the development of our hepatitis C guidelines. Oops. Now, 3 key messages I want to share. First of all, the good news is access is increasing in terms of numbers, but as we all know, there are still huge gaps that persist. We have very positive opportunities. More and more countries are actually really starting to scale up, and we have a few champion countries that specifically are moving forward. Some of them actually, some of the experiences have been presented in this conference. And again, if it is about reaching as many people as possible, including those who live in settings where there is compromised access overall, where the health services are poorly developed, simplification will obviously be key. So, just in terms of the numbers, about 3 million people have now been accessing DAAs, with the number increasing in 2016, in 1 year alone, 1.5 million, 1 million in the year before, in 2015. So that's really good news. And really, as I started to mention, several countries, Egypt, Pakistan, really being ahead of the pack, but several others are really following suit. And I'm talking primarily about low and middle income countries. There's Georgia, there's China, there's Brazil, and Mongolia, several others, in addition to many of the Western European countries and obviously Northern America as well. But the majority still remains unreached. 68 out of the 71 million people still do not have access. And as I think you are aware, just in 2016, global targets, global elimination targets have been launched, and they have been actually signed off on by 194 ministers of health at the World Health Assembly in Geneva. So there is explicit commitment that underpins that strategy, but the challenge obviously will still be to put that commitment into concrete action and actually translate it into access. But we would like to argue, and that's sort of what we are saying also in our access report, there are fewer reasons than in the past not to do it. And frankly, we are reaching a point that there are no good reasons not to do it anymore. As we look at where people live and what some of the current agreements are, 62% of people live now with HCV are in countries where prices of generic DAs can be as low as $200 per cure. That doesn't mean that this drug actually is available in all these countries and it is as cheap as $200, but we do have licensing agreements that from the R&D companies that actually can bring down the prices considerably, as I think you are very much aware of. This is what we call the cascade of testing and care for HCV, and this is from our 2017 report showing data from 2016. You see people infected, diagnosed, started on treatment and cured in 2016. The major message I would like to pass from this slide is that there's a major gap between those infected and those actually diagnosed. And globally, at best, 1 in 5 people actually have been diagnosed, and if it comes to people who are living in low-income countries, it's at best 10%, and it may reach up to 40% in high-income countries. But even there, many people remain undiagnosed. So testing in itself is a barrier, even though the price of diagnostic tests originally has come down. It can be as low as $1 per test. But confirmatory testing still continues to be more expensive. Depending on the product and the country, it can range between $15 and $100 and even more. So simplification, as I already mentioned, will be key, and that's again underpins very much the guidelines that we will launch in a couple of months. And there are 3 specific features that I would like to highlight and show with you the directionality of the recommendations that will be professional companies and associations, are also launching guidelines. I want to say that the way WHO developed guidelines is quite different. We follow a very rigorous approach of evidence review, the GRADE process. It takes a bit longer, but it's a fairly solid process that does go beyond sort of an expert review and expert opinion. So we are, as I mentioned, in a fairly advanced stage and hope to launch our guidelines in 2 to 3 months. One of the important areas that we are addressing is that we are now having simpler criteria to start treatment for all infected people above the 12 years of age. We now have simpler treatment to cure all subtypes, so there will be no need of genotyping, so that leads to another simplification. Obviously, with certain treatments and regimens being proposed and recommended here, that will lead to simpler approaches for procurement and supply chain management in national context. But also, we are very much talking about simpler service delivery models for a public health approach, where clearly treating hepatitis C should no longer be the domain of hepatologists in many settings, and in many places they don't even exist, but it should be really integrated and decentralized to the primary healthcare system. Yesterday in a session, the Minister of Health of Georgia talked about the Georgian experience, and it was really impressive to see how they are very proactively moving towards elimination in Georgia, but very much building on delivering treatment and the cure, basically in primary healthcare system and moving beyond specialist care. So in terms of the evidence reviews that have been done and are currently being concluded in our guideline work, just want to share a couple of highlights with you. You know that globally 400,000 people die every year of cirrhosis or liver cancer caused by HCV. You also know that cure can significantly reduce death and liver cancer, as we've also heard in an earlier presentation, among people with HCV infection, and we will have some numbers to that. We also know that cure can reduce comorbidities such as depression, diabetes, and chronic renal disease among people with HCV infection. So it goes certainly beyond the sort of hepatic benefits. Treatment is also shown to be effective and safe in adolescents above 12 years. And treatment for all obviously has to reach the most affected population. And again, there have been some other talks and there has been some attention in this conference to really looking at some of these other populations, specifically persons who inject drugs, also men who have sex with men, prisoners, sex worker, migrants, indigenous people. So really, if we talk about access, it's about treating all, but giving also specific emphasis to those people who are in many settings marginalized or not able to access the traditional services. Again, finalizing will happen in the next 2 to 3 months. We hope to launch those guidelines, and we certainly will want to have those guidelines ready prior to World Hepatitis Day. Thank you.
Thank you. Good. Questions? No questions?
Catching up on time. Oh, you may have one.
Perfect, we need time. So the next talk will be, again, thank you for coming. The next talk will be on hepatocellular carcinoma, and this is, of course, then the sequel of all these liver diseases, and this is still emerging. Now we have Professor Jens Ricke from Munich to talk us about treatment concepts and new data.
Well, I need my slides. I'm not sure if I'm the one to do it. Am I?
Here.
Push escape and just go on it. Never trust a radiologist who doesn't know his technologies, so it's not a good start. Very interesting day for me. A 10 years challenge coming close to an end. This is an investigator-initiated trial, as you can see, sponsored by the University of Magdeburg, where I spent a lot of time of my life before moving to Munich, and that's where we initiated this European multi-center trial. And I'm going to report on the palliative section on that trial. It's a rather extensive study volume. Sorry to do that. It's a prospective trial, multicenter, randomized, controlled, 38 sites, 11 countries in Europe and Turkey, and the primary Study objectives and design consist of 3 trial parts. There is a diagnostic study, there is a curative intention, and a palliative study. I'm going to report on the palliative results just for you to update the diagnostic study. Primovist MRI versus contrast-enhanced multislice CT was used for a stratification into a palliative or curative treatment. And if those patients were not eligible for the curation but fit in the criteria for the palliation study, radioembolization was added with sorafenib or compared to sorafenib alone, and it is a survival study. So randomization is plus minus radioembolization in a combination treatment. This is a study graph. I'll be very short on that. Screening phase, that's here on the left, that's where the diagnostic study takes place. The decision here being used to forward the patient into a curative arm, which I will not report on today, and into the palliative arm, which randomizes plus or minus radioembolization in patients receiving sorafenib. Dominant inclusion criteria for the palliation study, up to B7 points, BCLC Bs and Cs, not eligible for TACE, that was investigator discretion. Prior resection or vascular procedures permitted at various prerequisites that needed to be fulfilled, as you can see. Extrahepatic disease, very important, was allowed other than lung metastases. Exclusion to obtain a liver function, allowing for radioembolization as well as the sorafenib treatment, 1.5 upper limit of the normal range of bilirubin. Shunting is an issue for radioembolization, as you probably all know, and any previous external beam radiation to the liver was excluded. This is the most important graph, I believe, of that trial, teaching us a lot of lessons. This is a consort chart. I'll spend a few minutes or a few seconds on that, not minutes, don't worry, I'll be fast. 424 patients now finding themselves in the palliative arm were randomized for the intention to treat analysis, 216 receiving ZIRT and sorafenib, 208 receiving sorafenib. That's the intention to treat population. Now it starts to get interesting. Please recall, this is a trial combining an interventional treatment with a systemic treatment. Now we lost 68 patients that would either not receive the radioembolization, even though randomized in that arm, or not receive sorafenib, even though randomized in the combination arm, or receive no treatment at all. And on top of that, there is 38 patients we lost because we had 2 sites where compliance issues, and you find that down there on the left, where compliance issues prevented data obtaining from those sites. All this was reported to the national authorities. So we're down to 159 for the combination arm in the safety population and 197 in the sorafenib population. This is 15 more than expected because we had patients in the ZIRT plus sorafenib arm on the left, which would receive sorafenib only, so they go in the safety population. Now they're taken out again for the per protocol population, and protocol deviations, very interesting aspect, we can discuss it later, brings us down to 114 patients only in the per protocol population versus 174 receiving sorafenib only, and both groups without major protocol deviations, very diligently tested, very diligently looked after. These are the patient characteristics, basically what you'd expect, Child-Pugh class A, B, with a very minor proportion of B7 patients, stages B and C predominantly, as you can see here, liver dominant, some metastases, and all of this usually overlapping, so it was always liver dominant disease. And you can see that there was no significant differences between the groups in those patient characteristics when we were looking at the ITT population. This now is the serious adverse events related to treatment, so the safety population. And as you can see, the adverse events are very minor. Usually the treatment was quite well tolerated, and we didn't, and that's the important message, we did not see a significant or any major difference between the sorafenib only arm and the addition of the radioembolization. Now, this is the survival curve that we obtained in the intent, very important now, intent to treat population, ZIRT plus sorafenib as a sequential treatment. You start with the radioembolization, sequential radioembolization of the left and right liver lobe, and then you start with the sorafenib treatment versus the sorafenib only cohort. As you can see, median survival is 11.4 and 12.1 months. No significant difference. The curves overlapping in the intention to treat population. This is the per protocol. You can see the curves deviate, but please remind, we're looking now at 114 against 174 patients. Interestingly, we're looking at 11.1 months median survival for the per protocol in the sorafenib arm, so patients really receiving sorafenib. And we're looking at 14 months, roughly, likely 3 months survival benefit in the combination arm. That means only patients that would really receive the radioimmunization and the sorafenib as a combination treatment. However, with those small patient numbers, it doesn't reach significance, as you can see here. On top of that, with the per protocol population, it starts to get interesting when you look at the subpopulations of interest. Now, I start with the non-cirrhotic patients here, with a hazard ratio of 0.46, which I believe is quite remarkable, with a median survival of 22 months in the combination arm, and the sorafenib-only arm with 9.9 or 10 months. That is something that is interesting to look at, but note the small patient number in that subgroup. Again, per protocol, non-alcoholic etiology, very interesting moment here, I believe. Hazard ratio of 0.63, 15.3 months for the combination arm, 11.0 months for the sorafenib-only arm, with 64 against 101 patients in that subgroup. And the last one, the younger patients, benefited with a hazard ratio of 0.65 with 18.5 and 11.3 months median survival between the groups. We're looking at 43 against 75 patients here in that subpopulation in the per protocol analysis. So I'm summarizing the results now. The addition of ZERT to the sorafenib treatment regimen did not result in a significant improvement in survival compared to sorafenib alone. That's the intention to treat. The primary endpoint has not been met. Toxicity and safety was similar in the combination therapy arm as compared to sorafenib alone. And the subgroup analysis, as something that is hypothesis generating, suggests a clinical benefit for non-cirrhotics, patients presenting with non-alcoholic etiology, and the younger patients. We acknowledge specifically the sponsorship of the University of Magdeburg. This has been funded financially by Zirtex Medical and BioHealthcare. Thank you very much.
Thank you very much. Are there questions? Otherwise, I would have one first, maybe. So you showed some subgroups that have a better survival in this treatment. On the other hand, if the survival is the same in the overall cohort, are there also patients that have a lower survival and a worse outcome? Did you look at that? Older patients of more advantage, of course.
It's exactly the slide that I skipped 10 minutes ago. Okay. You'll see tomorrow. That's the forest plot. Other than alcoholics or the alcohol underlying disease for the cirrhosis, everything is to the left, meaning favoring combination. Not significant, most of it, but all of that forest plot is moving towards the combination. So I think that's a good answer. There is something, however, biostatistically, I mean, no question, it's a missed primary endpoint, but that's something, and maybe just as a general comment, we're facing a challenge in those combination studies, intervention and systemic therapies. It's off-label use. There is a strong bias, as you've seen. There was 24 patients not receiving sorafenib because the local investigators felt that radioimmunization was enough, and they didn't continue, so it's a major protocol deviation. We lose that. Many, many issues in a study format like that, which need to be overcome, lessons learned, so to say. Next time we're going to do it differently.
In my view, also important because you have some subgroups which are really related also to the underlying liver disease and the stage of liver disease, which is, and therefore it's also very important for the HCC that really there is an interaction of hepatologists, radiologists, and this is, I mean, also a very important set of data again. Yeah. There's no one fits all.
As well, that is the exact, I believe, the exact important comment. It's, you know, this very old daydream that everybody has. The doctors, the pharma company, medical device companies. One thing fits the whole HCC frame, and I give it to everybody. It's just not true, and that's what I specifically like about that outcome. it gives us a much better feel to what to say and what to do when you're sitting in your outpatient department trying to advise your patient. It gives us a closer look at who is the patient who will benefit.
Question. We're so late, but I think it's important.
So Lynn Peterson with Trends in Medicine. So I have two questions here. One, the subgroup analyses, were they pre-planned, pre-specified?
Yes, they were.
Okay. And on your protocol violations, were those mostly all in Turkey?
Sorry, I didn't get that.
The protocol violations, were they scattered everywhere or mostly in Turkey?
Turkey was not the worst, to be honest, not at all. Turkey is one issue, but it's scattered, interestingly, and that's, by the way, when asked me why we didn't pick that up earlier. We had an extensive monitoring program. You don't see it. This compliance issue, we found out just not too long ago, so we couldn't obtain the whole data and had to skip it. And the rest is something, it's incidents in between, and it's here and there. You don't pick it up. Don't ask me. There was an extensive monitoring program.
Final short question, short answer.
What would you do now differently, learned about this study? What would you do now, the next step?
The next step in terms would be defining the target group much better. What we're looking at is patients that are in very good state, in very good overall condition. They truly ECOG 0, the younger patients, very well compensated liver function. I believe that's the patient group that will benefit of that treatment. And of course, specifically, and that's that patient group, the ones with a non-cirrhosis are most likely going to benefit of that therapeutic combination.
Okay, thank you. So, final talk. Last but not least, coming back to NASH or metabolic liver diseases, and as just discussed before, prevention. Food insecurity increases the risk of advanced fibrosis and diabetes with non-alcoholic fatty liver disease. Dr. Sonal Kumar from New York.
So I'm Russell Rosemont. I work with Dr. Kumar. So thank you for all for your attention, those of you who stuck around. So we're talking about a very important topic today, food insecurity, which is when there's a limited or uncertain availability of nutritionally adequate food. This is unfortunately something that has been increasing in prevalence in the United States starting in 2008 with the Great Recession. And it was thought around that year, around almost 50 million were at risk going hungry. Whereas in Europe, a similar trend has emerged starting in 2010 with the advent of austerity measures, and about 13.5 million Europeans were thought to be at risk for food insecurity. And one of the major issues with food insecurity is as a result of food scarcity, when food is present or when they have the money to eat, people tend to consume very high, very dense, energy-rich, but very nutritionally poor foods. And this leads to an increase in obesity, most prominently in women, metabolic syndrome, and also doubling the risk of diabetes. And there are specific issues within those diabetics, namely at times of food scarcity, people with food insecurity tend to become hypoglycemic. At times of food abundance, they tend to have issues of poor glucose control because they're consuming this excess food in preparation for times of food scarcity, and also an increase in cardiovascular disease risk over 10 years. For these reasons, the American Diabetes Association has actually made it a Class A recommendation to screen for food insecurity when evaluating a patient with diabetes. And obviously, this audience doesn't need an introduction, doesn't need an introduction to NAFLD, but we all know NAFLD is closely tied to diabetes, metabolic syndrome, and obesity, and the rising crises with these issues. We know in NAFLD that fibrosis is the primary predictor of liver-related syndromes, specifically advanced fibrosis. So we know that food insecurity increases the risk of diabetes. We know that diabetes increases the risk of NAFLD. And we know that diabetes also is an independent risk factor for advanced fibrosis. However, this link between food insecurity and advanced fibrosis has never really been investigated. So the aim of our study was to investigate this association between food insecurity, or rather very low food security, and advanced hepatic fibrosis in diabetics with NAFLD. And to do this, we used the NHANES survey, which is the National Health and Nutrition Examination Survey, it's a group of cross-sectional studies run by the National Center for Health Statistics. under the Center for Disease Control, which is run by the United States government. And the survey consists of questionnaires of varying topics, including demographic information, socioeconomic information, dietary and health questionnaires as well as a medical examination and laboratory measurements. Certain ages and ethnicities are oversampled specifically, but sample weights allow us still to make national estimates. And we included all adult diabetics from 2005 to 2014, and we defined diabetics according to the American Diabetes Association guidelines, which you see here. And we identified those with NAFLD using a validated algorithm and excluding those with viral hepatitis, alcohol liver disease, AST, ALT over 500, which is not consistent with NAFLD, or those who were pregnant at the time of the survey. And to diagnose food insecurity, we used the NHANES Ask This survey, which was validated by the United States government, which consists of 10 questions. And they asked each adult over the last 12 months how often they had the following symptoms, ranging from worrying about running out of food, worrying about food not lasting until they got more money, cutting or skipping meals because they didn't have adequate money, or losing weight because they didn't eat enough. And based on the answers to those 10 questions, subjects were listed at varying degrees of food insecurity, ranging from full food security with no affirmative answers to very low food security with at least 6 affirmative answers. These were the 2 groups that we compared in our study. And we used multivariate logistic regression to assess for our outcomes. We controlled for 2 sets of covariates, covariates that affected advanced fibrosis, such as age, body mass index, gender, and race, and also those that affect diabetic glucose control, knowing that food insecurity affects glucose control. So factors such as diabetes duration, hemoglobin A1C, and insulin dependence. And we started with a weighted sample of around 300 million, and after our various exclusion criteria, ended up with a little over 21 million, 77% or so of which had full food security, whereas 6% had very low food security. And we found that, similar to other studies that I showed before, full food security decreased over time, going from 81% to 73.5% throughout the study, whereas very low food security increased from 3 to 8%, an increase of about 12% per cycle. And in comparing basic demographic and laboratory data, we noted those with very low food security to be younger, be more likely to be female, have a higher mean BMI, higher hemoglobin A1C, be more likely to be insulin dependent, and also have a higher prevalence of metabolic syndrome. Whereas in the liver-related laboratory data, there were no clinically significant differences between the 2 cohorts. And also in relation to their risk of advanced fibrosis, those with very low food security had almost nearly double the prevalence of those with very low food security had almost double the rate of advanced fibrosis than those with full food security, but this only trended towards clinical significance, so we performed our multivariate regression controlling for the factors we stated before. And what we found was that very low food security nearly tripled the risk of advanced fibrosis using our model. Other factors that were significant included female gender, a body mass index over 40, a hemoglobin A1C over 9%, and also a shorter diabetes duration. And we compared socioeconomic variables as well between the 2 cohorts and found that those with very low food security had were less likely to be white, more likely to have Medicaid or be frankly uninsured, and also be less likely to graduate university and have a lower mean family income. And in this model here, we use the same covariates as before, adjusting for variables that affect advanced fibrosis and also those that affect glucose control. And instead of using very low food security, inserted other variables that measure socioeconomic status. And what we found was none of them had quite the potency that very low food security had, and only one was positive, the graduation of secondary school, which really has very unclear clinical significance. The limitations of our study, the major one is quite obvious. It's the lack of histologic data in diagnosing NAFLD. However, we did exclude those with other causes of liver disease, and diabetics have over a 75% known prevalence of NAFLD. And to confirm advanced fibrosis, we used non-invasive laboratory measures which are well validated and recommended according to guidelines, but still not as accurate as histologic data. Our study was cross-sectional, and food insecurity is a cyclical process, so it's possible that we missed subjects who were food insecure. But we used, obviously, a validated survey to diagnose food insecurity. We had a very large sample size, and it was also quite diverse. So in summary, food insecurity is increasingly common. It is associated with almost a threefold increase in advanced fibrosis in those diabetics with NAFLD, and it's also a better predictor of advanced fibrosis than other markers of socioeconomic status. And we recommend that hepatologists now think of screening these patients for food insecurity, that we advocate for these patients as they are our most vulnerable patients with already significant comorbidities, and that our future studies we plan to look for outcomes involving food security and also plan interventions to prevent this process from already reaching this late stage. Thank you.
Thank you. Question? Maybe you need, yeah, you have a loud voice.
Yeah, so Dr. Rosenblatt, obviously people who are food insecure are very unlikely to have access to healthcare.
Right.
Yeah, how do you solve that problem?
Well, ultimately, that requires a whole restructuring of the American healthcare system, which I don't think we have enough time to discuss right now, but I'm all in favor of. But in terms of, I think there are easier solutions, and there are already programs that exist, programs in America such as Meals on Wheels that provide food and deliver healthy food to elderly people who can't leave their house, and other programs exist already, food stamps as well. But there's obviously a big part of the population we're missing. Obviously, some healthcare needs are going to be unmet just due to their lack of access. But in terms of providing them with food, which at least will help solve some of the problems, maybe prevent the hypoglycemic episodes, and then prevent during food scarcity and prevent those hyperglycemic episodes during food abundance, we could make some headway in that.
Yeah, that's also a related question that I had. It's because for those people who can afford food, the cheaper foods, the high carbohydrates, sugars, fats, things that are
right.
So could they be missed in your survey?
For sure. I mean, we know those with food insecurity tend to consume those energy-dense, cheap, nutritionally poor foods. And if you look at the cost of fresh vegetables and fresh fruits, those have risen over 100% over only a few years, whereas the rise in other less healthy foods is significantly lower. So they can afford those foods, that's what they choose. And obviously, it's at a certain point becomes instinctual. Just to survive, you need to consume some calories. So obviously, our goal would be to step in way before that.
You mentioned the school grade. Do we need more education? I made this point before in the schools, early on, around nutrition.
Yeah, and I think that's a great point. And not mentioned in this talk, there's an absolutely enormous population of children who are food insecure. Because you can imagine if you are a parent who is food insecure and you have children, that's its own problem to begin with. And that also is closely tied to the obesity epidemic in children as well. So absolutely. And free school lunches and other sort of social services that we could provide.
2 years ago, I gave a lecture for children, 10 years old, and they liked it. Yeah, I showed scary pictures of twos and with sugar and stuff, and I think it's important, even for the children. They remember this, recognize this.
Absolutely, they're eager learners.
Okay, with this, thank you again, and we conclude the session. And sorry again for being late, but we had important issues to discuss during the governing board meeting.